Hey, doctor, we are already alive. So,
Okay. Thank you. Thank you. Natalia, you want to say a few words? Either Dea or Andre say a few words in Spanish, then Natalia will say a few words, then I will introduce our panel, please.
yes, doctor. Buenos días, gracias por acompañarnos nuevamente. En nombre de mi compañera Deyanira Capi Casillas, quien es vicepresidenta del comité organizador de este congreso, es un honor para mí en esta primera instancia agradecer al doctor Jorge Herrera Ramos, señor embajador de la UNESCO y presidente de World Congress, así como al doctor Salim Al-Draouf, presidente de la Walter E. Dandy Neurosurgical Society, al doctor Babak Kateb, presidente de la Society of Brain Mapping and Therapeutics, and Brain Mapping Foundation, todos vicepresidentes de World Congress of Neurosurgery, a la doctora Natalia Francesco, encargada del área de Relaciones Internacionales de la Fundación Internacional de Neurociencias Jordi Herrams, al profesor Nasser Gandaur, presidente del Comité de Honor, y asimismo agradecemos el honor de tener a la mayoría de los doctores que marcan el paso al día en la neurocirugía en el mundo, que nos acompañaron con magníficas ponencias en este congreso. Muchas gracias. Doctora Natalia.
Yeah, thank you, Dr. Andre. My name is Natalia Fedorshenko, and I'm representing the organizing committee of the World Congress, the World of Neurosurgery in Your Fingertips. And I would like to say first a few words on behalf of Mr. Jorge Herrera, Ambassador of Peace and the Chairman of the Congress. Today he is on an important meeting tonight in the Geneva, so he's really sorry to not joining us today. And also today's topic of our meeting of most of the doctors who was performing in the Congress is with the topic, the challenges of neurosurgery in the new generations. And today we have the vice chairman of our Congress, Dr. Salim Abdullahouf, global president of the Walter Dandy Society. And also we have Dr. Babak Kateb, also vice chairman of the Congress and president of Foundation for Brain Mapping. We have our honor committee also of the Congress, Professor Nasser El-Gandour, and Dr. Deyanira Capi Casillas and Dr. Andre from the NS Medical Students Chapter in Mexico. Like, we are organizing all this together, so we are happy to have all of you today, and thank you our listeners for joining us for the whole week and for joining us today. I'm sure today will be really great discussion between the whole doctors, and Dr. Salim Abdullahouf will continue to moderate our meeting.
Thank you so much, Natalia, for your hard work throughout this week and doing this Congress with your time zone in Ukraine. You have stood up late at nights with us, and I really thank you for all your effort. Natalia is an exceptional, she's a neurologist, loves neuroscience. She's been supporting neurosurgery in her home country of Ukraine, so it's great to have her with us. I would like to also commend Deyanira, Andre, and their team of students in Mexico City, an amazing group of students belonging to the American Association of Neurological Surgeons, AANS group, and also the Dandy Society in doing the tremendous work they have done and they're done this week. I mean, I am just amazed by the dedication of these group of students this whole week, the amount of work and time they spent in that office to do that. We always say that new generation of medical students are not like us. They don't like to work hard. And this is a big thing we say in America all the time. And I'm not including all medical students, but this is what a lot of the professors say. This group of students in Mexico City have proven us wrong, okay? They are that generation that is working so hard outside of their classes. So I really commend them for that. More especially, I'd like to really say a word about the visionary leader of this Congress and the foundation that put this up, Jorge Herrera. What an amazing visionary thinker, in really trying to bring us all together. We will be actually recognizing him. He's never been recognized in our field for a lot of the things he's done behind the scenes. He's done all the work behind the scenes. He's not getting any of the credit. It is time for us to recognize this man, and you will see in 2021, we will be officially recognizing his efforts in helping us, his work all the way going back to working in sub-Saharan Africa, helping families and children, to all the way to putting us together. that cannot go unrecognized, and I will make sure that that happens. We have a group of really truly authorities from around the world with us here today, okay? And I want to recognize them. You know, they have been officially been introduced throughout the lectures, but I do want to just quickly tell you who's our on panel today as we have a larger discussion about our field. We have Professor Paolo Perini from Pisa, Italy with us. We have Dr. Sabaresh Natarajan. He is from University of Massachusetts in the East Coast of the United States. We have Dr. Charles Matak from New Haven, from Yale. We have Professor Dr. Ayub Sherian from India. A lot of you know him from his work in Nepal, but he is now in India. We have Professor Claudio Yampolsky from Argentina, from Buenos Aires. We have Professor Mohammed Fahmi from Egypt. We have Professor Nasser Al-Ghandour, also from Egypt. We have Professor Walter Jean from GW in Washington, D.C. in the United States. We have Dr. Baba Katab from Brain Mapping Society and Foundation. We have Dr. John Roffel from South Dakota, establishing his new position there as a skull-based vascular surgeon. Let's see if I'm seeing everybody on my screen. Did I miss? And Professor, of course, Professor Luis Amador, professor from Mexico City. We just heard his beautiful lecture this morning. Let's see, am I seeing everybody? Did I miss any of you professors? I want to make sure I'm not excluding anybody.
We have one more professor connecting, Dr. Salim. We had one more professor just connected us.
Okay, great. Professor Rosito, can you hear me?
Yes, hello.
Good to have you with us. Well, what are you sitting in Hawaii? I mean, we're sitting in the cold here. We're freezing. What is this?
This is Mexico City lifestyle.
Oh my God! You and Dr. Professor Amador and Dea and are living the good life, while we're struggling in the cold here. That's okay. All right, I understand. Well, it's good to have you with us. Good to have you with us.
Thank you for the invitation.
We have a beautiful panel with us here today from various regions of the world. And this session is a conclusion session for really an impressive Congress that's been going on. A lot of our viewers around the world have been medical students. And I think I'd like to have a conversation with the professors, larger conversation about the future of neurosurgical education in many countries, continents around the world. Well, the first question I want to start with, just to get to know each other, I'd like to ask the professors, how has the COVID crisis affected your practice, your training of your residents and students in your respective countries? How has this crisis affected, I'm very specifically talking about education under your guidance in your institutes. So I have Professor Paolo Perini. Please, Paolo, if you could tell me what the impact has been on education.
Yeah, in Italy, the COVID crisis affected quite a lot education for several reasons. First of all, we start doing neurosurgical education through the web. So there was a problem for the students to come in the clinic. So we start to do some lessons about the web. That was the first problem. For the residents, there were not so many differences because residents can come in the clinic to work with us, but there was a reduction of the elective surgeries because it is allowed to do only urgent cases. That means we can do vascular, tumor, but we reduce, we almost eliminated elective surgery like almost all spinal cases, you know. So we do only urgent cases, only cases that can deal with the life of the patient. So we reduce a lot of cases. There was a lot of work directed to the COVID. Also, a lot of nurses were involved in the COVID treatment, and also several anesthesiologists were dedicated to the COVID. So we have less doctors, physicians dedicated for neurosurgery. So that situation created some problems with education, you know. It's evident that education in this year had some relevant problems.
Right. Thank you, Professor. I want to ask the same question. I'm going to move to different countries. Dr. Matak, why don't you represent the United States and tell us what has the impact been on education during the COVID crisis?
I don't know that I can, the US is a big country, as you know, I don't know that I can do that. But for us, what it did, it definitely crystallized, like Dr. Perini was saying, the Zoom education. And so we really had an opportunity that the residents took the lead in organizing, more than weekly, I would say, maybe 2 or 3 times a week Zoom sessions where they would bring in professors from different fields even, to talk about neurosurgical topics. And that served the dual purpose of education and also keeping us together so that there's sort of a social support for people that are, maybe isolated and not with their families because they've traveled some distance to get trained, in our case at Yale. I think brain tumors and vascular continued, as much as ever because they're considered more urgent cases. The spine sort of did take a bit of a hit, but in this country, as you know, spine represents the lion's share of neurosurgical cases. And so I don't think it really impeded their overall education. I'm not sure that, the 40 laminectomies that they missed is gonna matter out of the 500 that they're gonna do in their training.
Yes. Thank you for that, Charles. Professor Claudio Jampolsky, could you please tell us what has the impact been in Argentina of the COVID crisis on education?
Yeah, thank you, Salim. Of course, in South America, the pandemic came later than in Europe and US. So we began late March, the beginning of April, with the close down, and we finished with all, or mainly all elective procedures. So the impact, as Dr. Perini told us, was similar in terms of the practice for residents. From April up to September, we did mostly emergency. And on the other hand, we changed our residents at the beginning of June. And we moved the end of the residence year and the entrance of the new residents to October. So they keep, they 4 more months at the same position. For the resident of the first year, he had to change usually in July. So he was first year resident up to October. And then we received the new residents. And of course, virtual education is growing up, webinars and everything, as everywhere. And now we are in a better condition. We are doing elective surgeries near 80% of what was usual. And I think we are going a little bit better, waiting for the vaccine, of course.
Yes.
That's everybody.
Thank you, Claudio. Professor Ghandour, give us a view. I know you told me earlier privately that, you've seen a few even colleagues die from COVID, it has hit hard in Egypt, in Cairo. Tell me, what has been the impact on education of your residents and students? We cannot hear you, Dr. Nasser.
Okay.
Yeah.
You know, Salim, first patient was recognized in Egypt. It was 14th February this year. And so the COVID-19 was hitting Egypt so early. And since that time, definitely there was a huge impact on both neurosurgical practice and neurosurgical education. And as I said in my presentation, which was exactly about this point, the impact of COVID on neurosurgical training and practice in Egypt and in Africa, we started to do a very important survey. This survey was a global survey. It was one of the earliest surveys done. I presented already the results in my presentation during this meeting. And then we published another important survey with 891 respondents from all continents about the impact on neurosurgical training. And this was published in the Neurosurgical Focus. It was very important. Definitely, clinical research at all levels has been suspended. Clinical articles replaced by reviews and surveys. Examinations had been postponed for both the degree of doctor and for the master degrees. Conferences have migrated from the classroom to the digital screen. We canceled two important meetings. The Egyptian Congress of Neurosurgery was supposed to be held at the end of March. We canceled another very important meeting, which is the Third Demands Congress. This is the Mediterranean Association of Neurosurgical Societies. This was an international Congress, and it was supposed to be in Egypt, held in Egypt in October. Both of them were canceled, but I did my best to organize with my meeting 30 webinars, and we were working hard and regularly each Friday. We were organizing regular webinars, and the last one was last Friday, where I gathered all the editors-in-chief in a very important event for the first time to be done. We had seven editors-in-chief of the top journals of neurosurgery with about 600 participants. And so definitely there was a great impact. And with the eruption of this new method of education, what we call it virtual learning, of course, we have to think about the future. Definitely, it is a turning point in the neurosurgical education process. And definitely there will be major change in the future. Nobody can know what is going to happen next year, but I think now we are well trained for any possible future crisis to occur or any future pandemic, that we have an alternative method of training. I know it cannot be completely alternative in neurosurgery, because neurosurgery is very important to develop skills. And as I said, maybe it's a proper way. It is time consuming, it is money consuming. Maybe it is very good method of education, especially in sub-Saharan African and developing countries, but still it's not the proper way to develop neurosurgical skills. Our work, part of it, important part, is doing cadaveric workshops, is doing hands-on workshops, courses to meet in person. That's another important point, that it develops social relations between all of us as friends. This is the proper atmosphere for neurosurgical education. Thank you, Salim.
Professor Ghandour, thank you for those remarks. You actually have scientifically looked at this issue, so your comments mean a lot to us. And you bring up the issue of the lack of the social interaction that obviously has affected all of us. And this, I want to take 1 minute to recognize another one of our panelists who just joined us, Professor Roberto Herrera from Argentina. As he's on the board of directors of the Dengue Society. He gave us a talk yesterday about bypass. Roberto, it's great to have you with us. I want to continue with the same question, since the US is indeed a very big country. Walter Jean from GW, what has been the impact on resident and medical school education from your perspective?
Well, I think for resident education, it hasn't impacted as much as the medical school students. Students have been off campus for a while now, and they just begin to come back, and then now we're having a second wave. and that's shutting things down again. So, you know, I think for the medical students, it's been really, really a bad thing. They canceled graduation. I mean, can you all remember your own medical school graduation, how important that was in your lives? And you don't actually have that. The residents, you know, in March through May, there were some changes in the case mix. They were doing more emergent procedures, but at the end of the day, when things got better again, everything kind of evened out. And I don't think that they are really impacted that much. I would echo Dr. Elgandor's point about cadaveric education. That's what I miss the most is, you know, not you can do a demonstration of a dissection by yourself in the lab and broadcast it, but you don't get to go to the table of a trainee doing the dissection and say, wait a minute, you're doing this wrong, or wait a minute, you're doing this excellent. Oh, by the way, but turn this head this way, you get more of a view that way. Those subtleties are lost in any sort of virtual meetings. As great as teaching has been, and I've certainly tried to do as much as I can with virtual teaching, as you all may know, with the North American Skull-Base Society, but it is still not face-to-face in front of a cadaver, showing and demonstrating and all that. So, you know, I've been vaccinated. I hope everybody does get that vaccine pretty soon. And, you know, a better day will be coming shortly. Having said that, I think this virtual thing is going to continue. You know, I think this is just an adjunct, another tool for us to use, and it's going to be a tremendous tool coupling with more traditional teaching in the future. And then my last point is, and as you know, my lecture for this group was about virtual reality. By the way, we could all meet in virtual space. We could all put on our goggles and actually see everybody's avatar. The only thing missing there, of course, is that we don't see everybody's facial expressions. So, but a day will come where we will be doing that, and hopefully we can actually demonstrate in virtual space some cadavers and skills and maneuvers and so on. So I think that day will come as well. Maybe, hopefully, don't have to wait for the next pandemic.
Well, thank you, Professor Jean. Actually, this crisis is ideally suited for the skills of Dr. Walter Jean and what he's trying to really do for us in the field of neurosurgery. So sometimes it takes a crisis for us to look at all the avenues. So that's great. And what Walter said, I mean, my whole career has been based on anatomic training and with cadavers. So I've been really hit hard by this and by not being able to train people in anatomic labs for sure. I'd like to ask I'd like to ask you the same question about the impact in India on education of residents and students, please, Ayub. I can't hear you.
Yeah, Salim, to be honest, I was not there in India during the time the pandemic hit. So I was in Nepal.
Right.
Well, in Nepal, we didn't stop anything. We were just wearing masks, and we were working till June without much precaution. We didn't have a choice. In fact, all our nurses, most of our staff, they didn't even get PPE kits. We didn't even have PPE kits, but we couldn't stop anything. So we went on and worked, soldiered on till June. And by June, we'd all got COVID. We'd all recovered. So we were all okay. And by June, I took the decision to quit Nepal. So I went to the farm. And so till October, I was at my farm. So completely isolated. So I really wouldn't know exactly how.
I respect that, Ayub. Thank you. Thank you so much. I'm going to ask Professor Amador to represent Mexico in answering this same question for us. Please.
Yes, sir. I agree with all my colleagues around the world. This time has been very difficult for the medical students. As Professor Walter Jean said, they are off campus, so they are taking their classes online. So it is difficult to have a good clinical experience. for the medical students. Now, for the residency program, we face two problems. The first one is the high number of COVID-19 cases in Mexico is very terrible. So in my country, there is no specific testing for the patient. So when the patient comes to the hospital, we have implemented some kind of protocol using CT scan in order to trying to identify those patients that had a COVID-19. So our institution is a non-COVID hospital. So we only face COVID when a patient with a neurological problem comes also with the infection. So we have taken specific measures in the OR in order to trying to decrease the aerosol formation. And one of my fellows developed a specific box to isolate the the patient's head for endoscopic endonasal procedures, for example. There was a very alarming data considering that during the endoscopic endonasal approaches, there was the largest spread of aerosol to the health people in the OR. So besides that, we are doing, as most of the hospitals, the emergent cases, aneurysm cases, pituitary apoplexy, etc. Some urgent spine cases. And also in the other side, we have our laboratory. So our residents can come to the laboratory and try to learn in the specimens or doing practices for micro anastomosis. But this is not enough because they already have this, and what they need now is the OR in order to acquire the necessary tools to become a surgeon. By the other side, the increased activity in the internet is very welcome. We have faced a lot of webinars. Sometimes there is a lot of sessions at the same time. Sometimes it's difficult to choose which one is better. One very nice model I want to hear from Dr. Mendez Rosito. He performed recently a course in which people from Pittsburgh, James Killiu, they perform some in vivo dissections in their laboratories, and they broadcast to the meeting. So this is a good example of how things can be improved during this time. Surely after the pandemic is over, which I hope for Mexico should be at least for the next 6 months, we need to keep going. And perhaps the theoretical learning is going to be higher during this time, and after we can compensate with good clinical cases.
Thank you, Juan. Professor Rosito, can you tell us a little bit about how this experiment went with transmitting? Can you tell us a little bit about it?
Yes. Well, obviously the pandemic hit us hard as in many countries, and we have in our hospital, we have the residents and we have a group of fellows, of skull-based fellows. And I'm in charge of the skull-based fellows, so I was really worried about the education that I could give this group of fellows for during this year. What we did is that we implemented a new lab that it had enough space in order to have social distancing and everybody with personal equipment, protective equipment. And what we did is that we did all the skull-based approaches in open and endoscopic. We did it through the year, through the months with the fellows, and documented everything. And at the end, we did a local course, limited people course, limited group of people were accepted in the course, and we shared with some international or different people overseas that they transmitted their cadaveric dissections, and so we could repeat it in our lab. And so, for example, we had from UPMC, they transmitted an endonasal endoscopic approach, and they showed us step by step through Zoom, and following, we did it in the lab with the students, and so it was a way of combining this. I called it this hybrid education through Zoom and at the same time with the cadaveric dissections, well, with all the social security measures, with social distancing and all the equipment and things, and thankfully nobody has gotten infected that we know of, and I think that it has been a good year for these students in order to learn in a different way.
That's very nice, learning about these hybrid ideas that people are developing around the world for education. Thank you, Professor Rosito. I want to move to a different question. We have a lot of residents who've been watching this Congress throughout the world, and obviously all the programs do some great things for residents, but I have a different question. If you were to identify for me, what are the weaknesses of residency training in your eyes of what you see in your place, in your hospital, in your system? So I think I know it's a more difficult question, but it's really the only question that will teach us. So I really want to ask a question. When you were trained as a resident and now when you're training residents, what are the weaknesses? What are the weak areas in how we're training residents? Sabarish, let me ask you first, if you don't mind. How would you identify your training, residency? You and other people will represent the United States, and then we'll have other countries speak as well.
The biggest thing is the exposure, I would say. The time we spent in the hospital as residents was much higher, especially with the strict 80-hour restriction that we have. I think we spend a lot more time in the hospital, but I would say as the amount of availability of knowledge from across the globe has increased now, I think it compensates for being there in the hospital and learning that by an apprenticeship model. You learn from everyone around the world. In fact, all of us learn from around the world, and our residents that join their club of learning that. I think that is the biggest thing, the time that the residents can devote to learning. And doing multiple things, including cadaver dissections, being in the OR, taking care of our patients and balancing that, especially for a small program like our program where we are growing.
That's great. Thank you. Thank you, Sabarish. Professor Roberto Herrera, can you speak about Argentina and tell me what do you think the weaknesses are of residency training?
Hello, Salim. How are you?
Hello.
We don't have residence programs. We have some fellow, and we interrupted this program this year for all the year. The condition in our country is the same that in the world, with many patients die for COVID, and the economic situation is very sad too, and it is very difficult to imagine the neurosurgery in the next future. It is very difficult for me to get excited about an ideal neurosurgery for the young people in the future. I'm very concerned because I see in my country and in the world a growing aggressiveness, violence, lack of love of the human being with the planet, with everything, with the noble causes. And worst of all, I see aggressiveness and violence between human beings. I believe that the world has better neurosurgeons than governments and political leaders. And I feel that while neurosurgeons are saving human lives, almost in some cases miraculously, those who control our countries and the world make our effort resemble that of the man who walks on the beach and returns some small shells to the sea so that someone of they can survive. But also as a neurosurgeon who loves what he does, and mainly as a human being too, I have hopes, and I know that this will also change and be better in the future. I really hope this, but nowadays, to me, it's very, very difficult to find well in the future, mainly for the novel neurosurgeons, for our residents, our fellows. I don't know. I hope this reality will be better in the near future, but I have my doubts about this. Sorry.
Thank you for those deep comments, Roberto. Yes, the political systems affect a lot of things in every walk of life. And there have been neurosurgeons around the world who have taken leadership role in their political systems, in their cultures, because they want to affect change. Neurosurgery, by definition, produces leaders. And some of these leaders are really become on the national level. There have been many examples around the world of people who are taking a stand because neurosurgery is really a leadership specialty. And I think Roberto, in a nice way, is saying that, and I just fulfilled my lifelong dream of writing a book that had nothing to do with neurosurgery, 3 Invaders, because I also want to bring about a positive change, So yes, we are shouldered with a heavy responsibility. You are all leaders, and we as neurosurgeons really are shouldered with larger responsibilities. Thank you for that, Roberto. John, Rafael, you're close to your residency. Tell me, what are the weaknesses in neurosurgical training as you have seen in the United States?
Hello? Yeah,
I can hear.
So yeah, I finished my training during the pandemic, and now I'm an attending during the pandemic. So I lived the 2 lives because I just recently started my practice. But I would say I'm gonna be the positive person. Like we talked about like a lot of challenges, but I put this slide behind me so everybody feel like there is a light at the end of the tunnel. So I think let's focus on the skull base and vascular. We're kind of lucky subspecialty in neurosurgery that I think hospital United States has still been allowing brain tumors and aneurysm to keep going as cases. I think the more specialized spine surgeons who should sit next to the wall and cry, but for tumor surgeons and open vascular, it's still being going. So I would say at the end of my residency, I clipped a lot of aneurysm. I have done a lot of cool tumors, and I think some of the chief residents still enjoying this because the practice has been shifting more toward the real cases, the big cases. So I would just because I'm a positive person by nature, so I try to take the situation to my advantage. Also. As for us as a neurosurgeon, we're smart people. There's nothing stopping us. Even we're losing few things, like for example, for educational part, we're losing the hands-on part, but the knowledge, spreading the knowledge, and even in my presentation, I pointed to this part and all the efforts from all leaders from neurosurgery around the world, like you, Dr. Salim, Dr. Charles, Dr. Walter Jean here in the United States. All those leaders are trying to communicate with other neurosurgeons, neurogeneration, and spread more knowledge, give more presentations. So I think maybe we can come out of this pandemic with better knowledge. And once we get to the point that we can put it some hands-on, people will have a better understanding and a quicker understanding of the anatomy, the techniques, even they lost sometimes putting their hands into the field, but maybe they will come with enough knowledge, which is still important to, if I have been training people in the skull-based lab at some point, if I see a person who already know how to do the farlateral or OZ or how to split the sylvia, even he read about it, he knows the anatomy, it will be way much easier to train this person and being more enthusiastic and pushing this person forward and do the dissection rather than a person who just doesn't know anything. So I'm trying to be positive. I'm trying to tell people, hang in there. Let's take advantage of what we have right now and wait until the waves goes on and be smart as neurosurgeon as we always be and take us to our advantage. That's all I can say.
Thank you, John. I'm going to ask Walter, also representing the United States, please chime in into this topic, the residency weaknesses in residency training.
Yeah, I actually have a very, I think, a big point to make here. You know, they're comparing my own training to what training is now. Obviously, the number of hours, absolutely correct. It's cut down for a good reason, though. Everybody knows that burnout is associated with hours worked, and I think that's a right move. And there's a lot of compensatory measures to make education whole with the hours shortened. But here's my point about the weakness of the current training process. There are a lot more procedures now than when I went through training. We didn't do thoracic screws. We didn't do a lot of things that we have now in the skull-based approaches and so on and so forth. So there are more operations to learn. And I don't think we're doing a very good job teaching when to use those skills. When is it right to use thoracic screws? When is it right to use a transnasal approach versus a far lateral approach? We are maybe great teaching all the elements of all these things, but we are not doing a very good job in teaching a coherent way of putting operations together and teaching about indications of certain procedures and certain elements of operations. Case in point is that, I'm going to get myself into trouble here, but the American Board of Neurological Surgery is having a fight with spine fellowship directors as to how aggressive spine surgery should or should not be. We are, in the skull-based world, facing the same problem of how big of small an operation should be. And nothing illustrates the point better than the vascular world, I think. Depending on where you train, an aneurysm is either 100% treated endovasculated versus 100% clipped. And that neither of those answers are the right answers. Somewhere in the middle is the right answer. But you know, if you train here, then you only clip. If you train there, you only coil. Well, what is the right answer here? I think that we got to come together as a group as neurosurgery, and also come to some sort of agreement as to not maybe how to do things, because we'll never agree about that, but at least how to teach things. Maybe that we need to come up with some sort of a scheme to say, okay, think through this from A to Z. That's how you decide on an operation. That's how you decide whether you're fusing from T2 to pelvis or only T2 to T5. We need to teach this better. We need to at least have a scheme of teaching this better, because we're just teaching them skills and say, okay, go do it. Do what? When do I do what? Is our weakness here.
Yeah, I think, Walter, you hit the nail here. The reason I'm asking this question, I've been really intrigued by this issue around the world, and I've given it a lot of thought. And you know, you mentioned the fact judgment. When do we teach people when to do something? And you also related the fact that the number of procedures we do. The problem is both of those things just have transformed over time, but we as leaders have not caught up to that. If you look at 1970 versus 2020, our mentors, forefathers who were training in 1970, and I did data analysis of this, there are only a few procedures that they were doing. You know, there'll be 5 or 6 procedures you need to learn, right? Today, I don't know, there are 50, 60 procedures that you need to be proficient in when you finish your neurosurgery. And the problem is we have the same system of training that was set by Osler and those guys in training back to 1950s and 60s that we still have today, that is being practiced between 1970 and 2020. So we're using the same system, but the whole field has changed. It's a different field in the world in neurosurgery. How do you adapt to that? We're very slow to adapt. So that is really an issue. This is why I'm asking you, you guys are all leaders, about your thoughts about this, because I propose a model to really reshape, rethink residency training, but obviously, you know, around the world, we've had people looking at it. I think this is an issue we as leaders have to really look at in the future, because I personally believe we are not producing any experts in neurosurgery coming out of a chief residence. I do not believe anybody is an expert in anything in our best programs, and we have amazing programs in the United States. I'm very proud of them. After 7 years of training, how many on this panel would have his mother MCA aneurysm, simple aneurysm, clipped by a resident that just graduated? How many of us will have our sister having her acoustic tumor resected by a chief resident just graduated? You know, how many of us will have our brother's aneurysm coiled, basilar tip aneurysm coiled by a chief resident who just finished at the top endovascular residency program? You know, see, that's the truth. That's where the rubber hits the road. Are we really who we say we are, or are we not? And the question is, for board certification, we say everybody's an expert in everything. So I don't know if the reality meets the road. And I think we, as the new generation of leaders in the future, truly need to look at this issue. And I really question whether our systems are geared as producing truly experts or mediocre people who are doing their best, and not their fault at all, okay? I was mediocre at everything when I finished my residency, and I came from an amazing residency at the time. We didn't have the restriction of hours, and I did tons of cases. Would I be the right guy to do some of those cases for somebody's mother or sister? I really doubt it, okay? So the question really is, what do we need to do to rethink this whole thing? And I'm bringing this conversation at the global level because this conversation needs to be had. And I don't want to be the only person who is really pushing this issue of reconfiguring how we do training, but it's an important conversation to be had. I would like to hear from Professor Fahmy from Egypt. Professor Fahmy, can you hear me? I don't know if he can hear me. Okay.
Hello, Professor Salim Abdul Raouf.
Yes.
I can hear you. I don't know if you can hear me or
yeah, I can hear you now. I can hear you now. Tell me, what is the weakness? Yes. Can you hear me?
Okay.
Yeah. Tell me, what is the problem in residency training in neurosurgery in Egypt?
In any education, there is a very important rule, which is a reaction, direct reaction between the teacher and the student. Any problem weakening this information transmission bond between the teacher and the student, like what has happened on COVID-19 on the last few months, will weaken the transmission of knowledge or the reaction between the teacher and his student. What happened in Alexandria or in Cairo, like any other area all over the world. In Alexandria, for example, from the history point, it is actually a reaction between a different old civilization, from the Greek, from the Pharaonic, from Islamic civilization. So we are accustomed to deal with the different culture. Regarding the main inquiry of you, Professor Salim, it is what is the weakening point is that we can, in the last few months, the reaction or the transmission of knowledge and the data between the teacher, the professor of neurosurgery, and the medical student in general, especially the resident. Regarding the lack of attendance, lack of less operative neurosurgical cases happened on the last few months, on Faculty of Alexandria, Egypt. I beg you to make a slight modification of your inquiry. Let us go for the future, what we can learn from the last crisis for the virus COVID-19. What will need on the more near future for give more communication, not only between the teacher and the student on medical school, but I need to trickle the point of a good cooperation between a different nationality, between the different scientists, between the different races all over the world for education and for a scientific research. This is a very high important point. It is a good cooperation all over the different country and the races from east and west, north and south. It is very highly important on the next few years, I guess. This is a very highly important point. We are not talking about resident in US and the resident in Egypt or resident in India and the weak point. Let us go for the future. Let us look for the future. How we can cooperate between each other, between the professor from one aspect, between different country, and from second aspect between to more bond, more reaction between the teacher and the student.
Thank you, Professor Fahmy, for those larger comments, humanitarian comments you have made for us. I appreciate it. Paulo, I want to ask you the question again about the training of residents in Italy. I'm not talking about COVID-19 at all. I'm just talking about the training systems. How do you see the problem of training of residents in Italy in neurosurgery?
Yeah, thank you for the question. That is very, very important. We'll need to have a lot of time to discuss in detail. But how should be a good residency? That is the question. In my personal opinion, that is a residency should provide, should allow the formation of general neurosurgeon. So the neurosurgeon that can deal with emergency cases. And however, another goal is to teach a method to become a good neurosurgeon, to become a clean neurosurgeon, a traumatic neurosurgeon, should provide the residents with a method. And to do that, you should have a good exposure and should provide a lab to understand the approaches to refine your technique. And should inspire the residents to understand what they want to do after. So it's very important to have in the country the fellowship. In Italy, the exposure is good because the residents can do a lot of operations also as first with some help, but there is a it's very difficult to have a lab. So also for me to have a lab, I came in USA. So, and there are no fellowship after the residency. And for me to have a skull-based fellowship, I went in UK. So the problem is, my opinion is that exposure is good, but to do the next step, so to become a neurosurgeon that can do more than MCA aneurysm, as we said before, to make the next step, you should do if you are a resident, you should do something more than the hospital can offer you. So you should try to find a lab and should go somewhere to do a fellowship. So the problems are this: the lab and the fellowship after the residency to take the next step. So
thank you.
Yeah,
thank you, Professor. Those are very good points. I hear this in many places around the world. What you just mentioned to me, it's been said to me by many professors around the world. I want to hear from Professors Amador and Rusito. What is the challenge for residency training in neurosurgery in Mexico? If you please, can share what you think the challenges are in Mexico for training residents in neurosurgery.
Diego?
Yes. Well, it's always a difficult question, as you mentioned it previously. I think that in our country, the main limitation, it's we have a lot of limited resources during the public hospitals where we work, and so many times it's not the ideal performing. We don't have all the equipment many of the times. That is one thing that it starts like when showing the residents the good things and the bad things, you know. Also the laboratory, I completely agree with the previous speakers. It has always been a limitation. Right now, we, as I mentioned previously, we just built or wrapped up our new lab. So I think it's going to be something good for the future for the residents. As I was telling them, I went and spent a long time in Little Rock and in some other places and in many other labs and things like that. And I never like was taught, for example, how to skeletonize the mastoid bone and the seventh nerve, as we are teaching it now today to our skull-based fellows. You know, now we are there with them and showing them the step-by-step of how to do a transpetrosal approach. So I am confident in the future that we are achieving a good way in order to improve the teachings of at least of how we were taught. But we are still having some limitations in equipment and in things. But the concept of education, I think, is good, and it can improve with learning with us, and also traveling around the world to Professor Abdul Rauf place, to Professors Walter Jean's place, and different places in the world, in order to have an open view and a global view of the learning. You know, that's my point of view.
Thank you, Professor Zito. Regarding Mexico, the difficulties or the weakness in residency programs, I want to also ask Professors Enrique and Professor Amador to make a point as well, please.
I can say something. Surgery is anatomy. So as Professor Yashagri used to say, we need to have a deep anatomical knowledge. So how can we get this knowledge? And this is through the cadaver, to the cadaver dissection. So in most of the countries in Latin America, it's very difficult to get the cadaver to make the dissection before the surgery. The former chief of the National Institute of Neurology and Neurosurgery here in Mexico, he used to say to us that he understood the surgery before he went to the cadaveric dissection, and then he came to the OR. So this should be the ideal scenario for any resident. So is this possible? No, most of the times it's not possible. During my residency, I remember the first aneurysm that I clipped wasn't the patient. So I didn't have the opportunity to practice before in the laboratory. Although we have a laboratory, we perform anastomosis, we insert aneurysms in the rat, etc. But it's not the same environment as the human anatomy. So, for example, you all know the model of Imad Dawood, for example, to have a living cadaver. So this is a good technique. So I think one of the things we need to work is in the laboratory in order to get the cadavers for the residents, so they can become familiar with the anatomy and also with the techniques. The other very important issue is the commitment of the faculty. We need to get the faculty to get more involved in the teaching of the residents, to write articles, to analyze each case. And one of the things that I think we have that is very useful is the analysis of the tapes, the videotapes of the surgery, because then you can learn, you can teach the resident step by step for some procedure without the surgical environment. I mean, you can do this in your office, and then you can take the hand of the resident. Look here, I'm doing this step. I'm using the scissor in this step. I'm doing different parts of the surgery. So I think this requires commitment from the faculty. And also, we need to see other people doing surgeries. As Diego Mendez said, we need to go abroad in order to see how Dr. Jean operates, how Dr. Rosito operates, how Dr. Salim Abdul operates, etc. So the resident can have a better scope. So we encourage our residents to have external rotations where they can see other people doing procedures, and this clears their minds. So this is a very complex entity, but these are areas of opportunity for us to grow.
Thank you, Juan. Professor Enrique, do you have any comment about weaknesses in residency training?
Okay, thank you very much. I hope you're listening to me.
Yes.
You listen? Okay, okay. Well, first of all, I'm very thankful to Jorge Herrera for the invitation to be here. And please don't be scared of me because I'm not a neurologist or a surgeon, neurosurgeon. I'm a pathologist. Nonetheless, I have some kind of idea of the complexities and problems around the education system in Mexico. And Dr. Mendez Rosito and I don't find Dr. Gomez Amador have pointed out the principal problems that we have in Mexico. The hospitals, the available for training, not always, or I should say maybe never have all the equipment and the technical and mechanical or physical conditions that we think are necessary or indispensable to the capacitation of neurosurgeons or any kind of specialist in our country. I should say that one of the possibilities that Dr. Gomez Amador and Dr. Mendez Rosito have already mentioned is the possibility of complete this education by external rotations. If in my hospital I don't have the possibility to do this procedure or this other procedure technique, surgical technique, well, it must be included in the academic program. Yeah. I don't, excuse me, I don't know the academic program of neurosurgery in my university. Sorry for that, but I doubt it. I have my serious doubts that it includes this possibility. And if it does, it must be thought or based on the judgment of experts like Dr. Gomez Amador and Dr. Mendez Rosito and others experts. So our residents could finish at least the minimum of formation so they could go to USA or Europe or other countries to complete this formation. I think this is the critical point. We don't have it, okay, I send you where they have it. Thank you very much.
Thank you, Professor Enrique. That's a great point. It's part of the new systems we're looking at and so forth. That is a very, very important point you make. As we're coming to the tail end of our closing ceremony here, I'm going to ask each one of you one simple question. We have a lot of medical students from around the world who are watching this. A lot of them are interested in pursuing a career in neurosurgery. If you were to give them one advice, you are a medical student and you want to give them one advice, what would that advice be? Professor Enrique, you're not a neurosurgeon, but I want to ask you, what would you advise medical students? One advice.
Well, don't ever let to follow your dream. Don't ever. If you want to be a neurosurgeon, you must be the better neurosurgeon, not in this country, not in this continent, but in all the universe known and foreknown.
I love it. I love it, Professor Enrique. I love that. That is so cool. Thank you. Thank you so much. Professor Paolo Perini, one advice for medical students who want to become neurosurgeons.
Yeah, generally some young students come to me to have some suggestion. I say that to become neurosurgeon is a very, very important choice. So before to decide, be sure that is your inspiration. So come here, come to see, stay here, the day, the night, understand what what you will do, what will be your life, and only if you are sure that you will do a real contribution to this field, come again. So that is my suggestion.
Paolo, you're saying what I always say. I tell students, neurosurgery is a diagnosis of exclusion, meaning you must decide you don't like anything else. You will be miserable doing anything else except that's the only time you should go in neurosurgery. So I tell them if the choice is between dermatology and neurosurgery, pick dermatology. If the choice is between ophthalmology and neurosurgery, pick ophthalmology, okay? Don't know, there should be no question about this fact, all right? So it's a diagnosis of exclusion. Thank you, Paolo, for that nice comment. Juan, please, what do you think, Professor Amador? What is your advice?
Anatomy, professor. Study anatomy.
Anatomy.
Not the crude anatomy, but the surgical anatomy, topographical anatomy. I think this is the basis for achieving a good result in neurosurgery. I think this is the foundation, and from there you can go away.
Yeah. Juan and I come from the Al-Mifti Yashigul school, so obviously we're very anatomic based, and that's great. Good to hear that, Professor Amador. Walter, please, what is your advice for medical students?
I have one point to make about the anatomy. The anatomy is, I agree with everything that's been said about that, but for medical students, they have to be a little bit careful about it, because if they start going to read Roten, they're going to get completely lost. The basis of learning anatomy, you have to know a little bit about neurosurgery and the operations before you go digging into Roten, because if you've done the operation, now you know what anatomy you actually need to know. So careful about diving into anatomy, just, reading the encyclopedia from A to Z, it may not be the best idea. That's the only thing I have to say about that with anatomy. The other part is I'll echo what I said to you, to the medical students at the end of my lecture, which is that if you're sure that this is your field, and I agree completely that this is an exclusion kind of diagnosis, then be as hungry and as thirsty as you can. Drink up every source of knowledge that you can. And in this day and age, that means YouTube, that means Twitter, that means social media, that means books, that means PDFs, that means in all sources. So don't look for knowledge only where traditional forms of communication lies, but in everywhere, in every corner.
Thank you. Thank you all. Each professor is giving us one pearl, that you can catch on. And the word from Walter is thirsty. Be thirsty. I love it. I love it. Professor Ghandour, one advice for medical students.
Salim, my advice is that make the sky your limit. You can do miracles, really. And there is nothing more important than saving life of a patient. That is the most important thing. Neurosurgery is an art. If you think about money, don't come to and take neurosurgery.
Right.
If you like it, you will be successful. I like what you said, that neurosurgery is a leadership specialty. Thank you.
Thank you. Beautiful. Yes, neurosurgery is an art, Professor, and that's a great comment. I love it. Dr. Charles Matak, please give our students one advice.
My advice is that is that you find a mentor. I think fundamentally, neurosurgery is still a mentorship, apprenticeship relationship. You need somebody to guide you, to motivate you, to encourage you. And I think that's true throughout your junior career as well. I would go well out of my way to find a mentor that believes in you and that wants you to succeed.
That's great. Thank you. Thank you. Mentor. That's a word I will remember from Dr. Charles Montauk. Such an important concept, as we go through here. Sabarish, please, what would you recommend young medical students who want to do neurosurgery?
So I think Charles took my stole my thunder there, mentor, which is really what I was going to say. But I think after that, I think the next thing is be open to change. I think the way we do neurosurgery changes every decade. It's about the patients. It's about giving them the best care and getting them across to their lives. So be open to changes and, like endovascular, open vascular, all of that, right? Don't give up on what you learned, but change and think radically about how you choose to give the right thing for your patients.
Sabarish, that's beautiful. I'll remember you for saying not to be dogmatic. I remember I love microsurgery, like clipping. When endovascular coiling came along, I said, no, there's no role for anything else because it's only clipping. And it took maturity for me to grow up and say, no, what is best for the patient? Is there some other avenues that can be used in certain patients that may be better for them? So this idea of dogma is very big in neurosurgery. We all come from very, dogmatic background of people, big name professors who teach us. We tend to become very dogmatic, and it's very dangerous. And I think what Sabarish said is so, so important, not to become dogmatic. Like some of my great mentors and teachers who were some of the best in the world are very dogmatic. I think it's important for me not to become like that. I love everything they've taught me, but I don't want to become like that. I think that's very important. Professor Yampolsky, Claudio, what is your advice? I can't hear it.
Sorry, Salim. I was also thinking of the mentorship, but it's already been said. So I would say follow your dream, try hard, and think you can change the life of many people, helping them. You're a physician. So neurosurgery has to be the tool to help people.
That is beautiful. That's beautiful. I love this because I tell in many of my lectures around the world, don't see yourself as the biggest person in any room. There are things bigger than you, and we tend to be very egotistical in neurosurgery. So we always believe we are the most important thing. And I think to think beyond that, to think that things are important than you, there are things that you have to live for that are beyond just you personally. And I think that is a more important message in neurosurgery than any other specialty. And I love that, Professor. Thank you. Thank you. We come to, I'd like to ask the same question to Professor Rosito. Can't hear you.
Yes, can you hear me well?
Yeah,
yes.
I can hear you.
For me, something that it's a big responsibility for me. For me, neurosurgery and skull base, it's my passion. And so I try to transmit this to my residents and my fellows. And for me, it's a big responsibility because I feel their passion. I feel all of them, their passion. And it's a big responsibility of us as mentors to guide them well, as the previous speaker said. So for me, the most critical word is passion and our responsibility to guide correctly our students. As
Thank
you said.
Yes. That's beautiful, Professor Rosito. The mentorship, when medical students, they need to know how passionate you are for them to think what it is. I love that. I love that. Thank you so much. Dr. Muhammad Fahmi, one advice for medical students who want to go in neurosurgery.
Yes, one advice. I think I can choose this. Make your target and the aim very high. However, go for every details you can go to reach this high target. That's it.
Work hard, work hard. Thank you, Professor Fahmi, great advice. Dr. Kateb, you're not a neurosurgeon, but you're involved with a lot of neuroscience. What would you advise a medical student who wants to go into neurosurgery?
First of all, I thank Dr. Herrera to set up this conference, and UNESCO and Walter Dandy Society. Well, I mean, I think as we know, neurosurgery and neuroscience going to change because of new technologies coming into the practice. For example, the coiling going to go away because of the new nanoparticles that will be taking their place. So the field of nanoneurosurgery is growing rapidly. AI, machine learning, and also augmented reality will change the way that medicine is taught and learned, and also the way that we are treating neurological disorders. So with that in mind, I suggest that our colleagues and our students learn about other disciplines and how those impact them. I train many neurosurgery residents, and I have 14 fellows on the research side, but also I recommend all of us get involved in the policy, because as you know, I was advisor to Obama for Brain Initiative, and under Biden we have we are in touch with transition team. So I recommend that all of us, including our neuroscientists and neurosurgeon friends and students, get involved in the neuroscience policy.
Thank you, Babak. Thank you for those words. The involvement in many different areas is very important as we grow as leaders. So those are beautiful words. John Rofel, one advice for medical students who want to go into neurosurgery.
Yeah, so I would say always keep in your mind, neurosurgery is not a sprint, it's a marathon. So it's a long way to go, and you have to maintain your energy, be smart, be hungry, as like Dr. Jean said, and your goal to be a safe surgeon. You do not need to be the best neurosurgeon in the world. You need to be a safe surgeon. You don't want to hurt anybody. So if you want to learn a technique, learn it in a way to do it safely, and keep practicing and practicing and practicing. Nothing taught me skull-based surgery other than practicing in the lab and working in the cadavers for hours, and for, I would say, like for a tremendous amount of time. So it's a marathon. Be a safe surgeon.
That is great. Just hard work, pure hard work. Those are great words from Dr. John Rofel. Finally, Professor Roberto Herrera, one advice for a student who wants to go into neurosurgery.
Yes. I say that study hard. When them become doctors, defend the life of each patient as if it were your own life. Make your dreams come true, and never lose hope, even in the face of the adversity. This is my advice.
Thank you, Roberto. What beautiful words we have heard from our esteemed panel today, ranging from sky is your limit, neurosurgery is an art, be thirsty, find a mentor, not be dogmatic, to open to change, follow your dreams, change the life of others, you know, in effect, in a positive way, the life of others. You are not the center point. Show them your passion. It's not sprint, it's a marathon. And the life of every patient as if it's your own family. Beautiful words from the various experts we have here today for our medical students around the world to hear from people who have had journeys, long journeys in a very challenging specialty in medicine. It's been a great week. I would like to acknowledge Natalia for the tremendous work. I acknowledge the Mexico City Students Group, NS Dandy for their work. I would like to commend Dr. Jorge Herrera for the visionary work in putting this together. I have nominated and brought him onto the executive committee of the Dandy Society as an external advisor because of his visionary thinking and work. And we will acknowledge his contributions officially in 2021. So it has been a great effort and time by all of you, the professors, and everybody behind the scenes who has been doing this work with us. We are honored to have you with us, and we look forward to future such activities. Hopefully some will be face-to-face sometime in 2021. We get to see you all from that perspective. Natalia, a few words from you.
Yes, thank you very much, Dr. Salim Abdulrauf, for your great work, for your great arrangement of everyone's talk, questions, and everything, like how to pass the ball through the talking. It's really great because, like, you know, everything is dynamic and everyone has the time and part to say some words. It's great. Thank you to the all doctors I see today, and I'm listening to all of you because nowadays I'm actually a resident. I'm not in neurosurgery but in neurology, but you're discussing really actual questions, and it's really something which should be improved because every time the education changes and we need to stick to the new standards, not only to the old ones, like, and that's really great. So thank you also Deya, thank you Andrea, and really everyone. It is a great pleasure for me to be with you because you are really great personalities all over the world, and I hope one day I also can at least a little like join your level. That will be really great.
You will.
Thank
Yes.
you. And also thank you, of course, to the Mr. Herrera because for his support, for believing in me, and that's really great. Yeah, thank you everyone, like sincerely.
Greetings to all of you. We took a lot of your time on a Sunday. For some of us, it's early afternoon. For some of you, it's in the evening. And your dedication to education of the next generation is shown by your comments, by your passion, each one of you. I could feel it in your words, and that means a lot to us. So, I officially close the Congress right now. For the week. It's been great, good for all of our audiences from throughout the world. Some of us joined us from very difficult times in the middle of the night around the world. It's been great with you. Until next time, it will be our honor to see you all again. Thank you so much. Deya, please go ahead and take us off the, okay.
Thank you very much, Doctor. We're getting
Thank you so much.
Thank you, everyone.
Thank you.
Thank you. Thank you.
Thank you.